On examination, the child is sitting in a tripod position, leaning forward with his arms on his knees. His temperature is 39.5 degrees. Respiratory rate is 40 breaths per minute, and he appears anxious and restless. You notice inspiratory stridor and a muffled, hot potato voice.
What are the key features in this presentation that raise concern for acute infectious airway obstruction?
The key features include fever, difficulty breathing, neck swelling, drooling, refusal to eat, tripod position, inspiratory stridor, and a muffled hot potato voice. These suggest impending airway compromise, particularly acute epiglottitis, which is an airway emergency.
What conditions should be included in the differential diagnosis for acute infectious airway obstruction in this child?
The differential diagnosis includes acute epiglottitis, characterized by high fever, drooling, a hot potato voice, and the tripod position. It is less common now, due to the Haemophilus influenza type B Hib vaccine. Bacterial tracheitis, presence with high fever, stridor, and respiratory distress, often following a viral prodrome. Croup laryngotracheobronchitis, presence with stridor, hoarseness, and a barking cough. Less severe cases respond to steroids and nebulized epinephrine. Retropharyngeal or parapharyngeal abscess, symptoms include neck swelling, pain, torticollis, van-limited neck movement.
What immediate steps should you take to manage this child?
Keep the child calm and in a position of comfort. Tripod position. Avoid placing the child supine or performing any unnecessary procedures that could worsen airway obstruction. Call for immediate assistance from pediatric anesthesia and otolaryngology. Prepare for possible airway intervention, including intubation or a surgical airway. Administer oxygen to maintain oxygenation while minimizing agitation.
Why is it important not to place this child in a supine position or perform unnecessary procedures?
Placing the child in a supine position or performing unnecessary procedures like blood sampling can provoke agitation and cause acute airway obstruction, which may lead to a life-threatening situation. Keeping the child calm and in a position of comfort helps minimize the risk of rapid airway collapse.
What is the preferred method for securing the airway in this patient?
The preferred method is intubation in a controlled environment, such as the operating suite using an inhalational anesthetic. This minimizes the risk of sudden airway collapse and allows for a more controlled and safer airway management. A pediatric anesthesia team should be present, and in case intubation is not feasible due to airway swelling, a surgical airway tracheostomy may be required.
What potential complication could arise after the resolution of airway obstruction, and what is the proposed mechanism?
The potential complication is post-obstructive pulmonary edema (POP), which can occur in 2% to 10% of patients with upper airway obstruction. It develops due to negative intrapleural pressure during the obstruction, increasing left ventricular afterload and pulmonary venous pressure. The condition typically resolves within 72 hours and can cause significant oxygenation failure, but it often responds well to positive pressure ventilation with PEEP.
The child was diagnosed with acute epiglottitis, an airway emergency. The pediatric anesthesia and otolaryngology teams successfully intubated the child in the operating suite. He was started on antibiotics and closely monitored in the PICU. After 48 hours of supportive care and treatment, He showed significant improvement and was extubated without complications.